Good evening, doctors. On behalf of Harmonica Akumentis, myself, Shubhojit Mukherjee, SBU Head Sales and Marketing, welcome you all. In fact, Harmonica Akumentis, along with Kasturba Medical College, Manipal, is embarking on 6 online modules, which is adding pieces to puzzle, solving the enigma of endometriosis. This will be done with the help of Kasturba Medical College, Manipal, and Dr. Pratap Kumar, who is the head of the Department of Reproductive Medicine and Surgery, is going to help us do this program. So it's a pleasure that this is our first program, and I'm very happy to tell you that 800 to 1,000 registrations have already happened, and I'm sure in months to come we will have more numbers. Doctor, it gives me great pleasure to introduce the chairperson of today's first program, Dr. Hrishikesh Pai. I mean, he needs no introduction, but I take pleasure of introducing Dr. Hrishikesh Pai, President-elect Foxy, Group Liaison, FIGO Women's Cancer Committee, Director, Bloom IVF Group. Dr. Pai is also Administrator of Foxy Manyata Project, past appointment, past Secretary General Foxy, past President ISAR, ISGE, MSR, and MOXY. He has won 58 awards, including honorary FRCOG by Royal College of OB-GYN. Dr. Pai, it's a pleasure and honor to have you with us for the first program as chairperson. Over to you,
Thank you.
Dr. Pai.
Thank you, Subhojit. It's a pleasure and honor to be here with you all today. And, I am really honored because today's speaker is Dr. Pratap Kumar. He is a fantastic, I think, after B.N. Chakravarti, he's the real professor of the country and true academician, dedicated professor for so many years. I remember in 1991, he started the IVF unit. So he's one of the pioneers of IVF in India. And not only that, highly academic, fantastic individual, good human being. Was also the vice president of Foxy. I always tell him when I meet him that he is anytime he can become the president of the federation. So he's got that ability in him, and he's also has received the lifetime achievement award at the Manipal University, the famous Manipal. Who doesn't know Manipal? And who doesn't know Pratap Kumar in the Manipal Gynec department? He has been the head of department of gynecology in the past, and it's a pleasure to introduce you to him. And he's going to talk to us on pathophysiology of endometriosis, which is a very complex topic, and I think only Pratap can do justice to it. The floor is all yours, Pratap.
Thank you very much, Hrishikesh Pai, for a lovely introduction. So, Subhajit, would you like to continue?
Yeah, thank you. So, before we get on with the program, I'll just take a minute or two and introduce my company, which is Akumentis. Our division is called Harmonica. Doctor, at Akumentis, our vision is to become a global healthcare company, empowering each and every patient on the earth with novel healthcare solution to fight their discomfort. At Akumentis, Doctor, we have 9 strategic business units. We have the women's health, which constitutes the major part of Akumentis business, of course, followed by cardio diabeto, ortho, pedia, derma, and the general segment. And at Harmonica, we serve through gynecologists, obstetrics, and IVF. Next slide, please. And I have great pleasure in introducing you our parent company, Dr. Akume's Drugs and Pharmaceutical. In fact, many of you may be aware, may not be aware, but I take great pleasure in telling you that Akume's is the largest contract manufacturing company in India. And we do manufacturing to the tune of 12% of Indian pharma market. Means the whole concept is if 100 capsules, tablets, injections are sold in India, say on a given day, 12 rupees is manufactured by Acume. So that's the ability we have to manufacture. and Akumentis, of course, is the sales and marketing wing. Next slide, please. And at Harmonica, we have primarily therapy related to medical management of uterine fibroids. It's represented by FibroEase 10 and 25, which is low dose mifepristone. Then, of course, medical management of endometriosis, we have Dynofirst, Dynogest 2 milligram. Then we have medical management of PCOS. We have Ushorem, which is minoanisotol, decairo, metformin, L-methylfolate, and mecobalamin. And of course, in IVF therapy, we have Endothic, which are estradiol valerate, clomipure is our clomiphene citrate with melatonin, OFM plus, and Michelle is our micronized progesterone. So this is in a nutshell about what we manufacture, what we do. And without wasting any time, Dr. Pratap, it's all yours on the subject of endometriosis.
Thank you very much, Subhajit, and for your contribution for academics. And special thanks to Hrishikesh Pai for having introduced me so well from his heart. And I would take you through the new concepts of changes in understanding the pathophysiology. As mentioned just now, this is the first module, and the next 5 months, every Thursday, first Thursday, we'll have this program on endometriosis. There'll be different aspects covered by different people who are experts in the same field, and also chaired by some eminent people from the country. I bring greetings from Manipal University of the Karnataka state. We are in the southwest of India on this coastal region, and that's a university building with 4 floors of library for students and 4 floors of administrative wing. We all know this distortion of anatomy, everybody knows this, which prevents fertilization. But we also know it's a chronic inflammatory process. Thereby, folliculogenesis, fertilization, and implantation may be a problem. Everybody has been taught, and we have heard these theories for several decades. I'm not going to talk about these theories. They are actually called hypotheses. They have never been proved. But we know that when there's endometriotic bleed onto the ovary or any other place, it's a toxic element because iron contains a lot of oxidative stress. Now, what happens is blood in the ovary or any place, the macrophages are there in the peritoneal cavity. They actually, the iron sequestrated by the macrophages eat up the iron. And then these macrophages are overloaded with iron. During its attempt to destroy iron, it produces a large amount of superoxide ion and hydrogen peroxide ion. What does that mean? It means it's once again a chronic inflammatory process. It's a pro-oxidant. Thereby, one of the potential pro-oxidant is iron. That is where the hemoglobin ion is in the blood of the endometriotic areas. So the role of iron in the oxidative stress in pathophysiology and endometriosis, long back I published this. That's a new concept. But beyond that, now we know that the free radicals and antioxidants have a kind of a balance or imbalance. And because of oxidative stress, all these inflammatory processes, especially the nerve injury occurs. That is why there's severe pain in endometriosis. So endometriosis is all connected to gene alteration by oxidative stress, inflammation, and of course, estrogen dependent problem. The free radicals will once again cause additions. It decreases the ovarian viability and actually even the volume sometimes. And the toxic to sperm, plasma, and acrosomal membranes. There's a loss of motility because of chronic inflammation, and they do not penetrate the egg because they are kind of lost in its potency. Arrested division of fertilization and embryo death. So all possibility effect of endometriosis on peritoneal factors, chronic inflammation, the ovary, oocyte, sperms, as well as the fertilization. Interestingly, some people like Giuseppe et al. Have published a new thought. Is it connected to newborn bleeding? The girl who just born today has a bleeding tomorrow. And we always say, oh, it's because of progesterone withdrawal of the mother. But things have changed a little bit. They identified peritoneal reflex from neonatal uterine bleeding or occurring around 5% of girls at birth as a biological, plausible, and likely cause of early onset of endometriosis. Interestingly, the newborn has a long cervix. There's a lot of mucus plug in the cervix. Hence, whatever little bleed from withdrawal bleed occurs, it doesn't come out. It just goes backwards and falls in the peritoneal cavity and kind of become like a stem cell in the future. All these peritoneal factors may get exacerbated in adolescent. Hence, the stem cell of an endometriosis is all connected to newborn bleed, which can remain dormant for several years to go on. The endometrium consists of luminal epithelium and the glands and can be divided into all these kind of basal layers and the functional layers. So what happens is this epithelium, the endometrial cell gets into the deep part of the gland, and the endometrial, the basalis contains a small population of epithelial stem cells and stromal stem cells within the so-called endometrial niches. So these newborn thing goes and gets stuck in those niches. In biology, the term is commonly used to describe an entity or a concept that is based on what is generally accepted or inferred even without a direct proof of it. That means there is no direct proof, but we think is another hypothesis, or maybe it actually happens. So do stem cells, the progenitor cells, play a role in endometriosis pathogenesis? Maybe yes. When adolescent bleed, menstruation occurs, that newborn who had bleeding long back may start bleeding once again. Hence, we have a role to play to the mother of this girl newborn when she becomes adult or a menarche in adolescent time. If she gets a lot of pain, I think there should be endometriosis. The thought of should be there. So multipotent, self-renewing adult stromal cells that reside in both the basalis and the functionalis of the endometrium, they can remain dormant for prolonged periods of time and undergo multilineage differentiation in vitro. So lots of things have gone on, like Sampson's theory, retrograde menstruation. Of course, to confuse it more, bone marrow-derived stem cell, which I'm not going to talk about, because there's a lot of research is going on that. But I would probably take you through how these bleed can occur into the rectovaginal spaces and remain dormant, and under the influence of HOXA10 gene may be driven to originate endometrial cells at misplaced locations like rectovaginal septum, uterosacral ligaments, pouch of Douglas, broad ligaments, and the colon itself, rectosigmoid colon. So these little cells from the newborn may remain dormant and get into problems later. But interestingly, over the years, we realize endometriosis is estrogen dependent, but also progesterone resistant. It's an emerging feature of the disorder. Whatever progesterone we give, it is not a permanent cure. But I know Dynogest has replaced all progestogens in a clinical practice. It's a very effective product because it comes from 17-nor testosterone. But delayed transition from the proliferative to secretory phase as evidenced by dysregulation of progesterone target. What does it mean? It means till now, whatever progesterone we use, there is resistance for the treatment. This is never a permanent cure. Why is it resistant? Limitations of current hormonal treatment. So research has gone on beyond looking at the progesterone. Why is there resistance? Because the Human Genome Project came up long back. We know that 100,000 genes have been studied, which are a part of DNA that encode proteins. What is happening is they discovered 20,000 protein coding genes, which comprises of only 1% of human genome. That means the 99 remaining percent, they told it as a junk gene. That means they thought that 99%, they did not know what the role was. Only 1% was studied in Human Genome Project. Now, interestingly, that 99% of the junk gene is the main source of information about endometriosis. These stretches of DNA, in fact, have important biological functions, like which are integral for protein translation. So imagine the junk genes have been studied. It's not junk anymore because they found, as a student, I didn't understand much about DNA and RNA. I used to close off my mind for that. But let me explain to you. When you say DNA, it means basically the nucleus of the cell. But when you say RNA, it means it is found in the cytoplasm of the cell, although it is usually synthesized in the nucleus. That means DNA is in the nucleus, RNA is in the cytoplasm. The DNA is stored in the nucleus because it is too large to come out of the cytoplasm. Now, why I am bringing that point is something called as microRNA. Lots of research internationally and nationally in India also studies have been going on with microRNA as invasion promoting factors, is a new player in deep endometriosis. Let's understand what is this microRNA from this RNA. Lots of papers have been published because this regulation of expression of microRNA is the main contribution of endometriosis in the near future. Lots of drugs will come up towards this regulation of microRNA. So when you look at this, DNA provides the code for cell's activities, and RNA converts that code into the protein to carry out cellular function. But this microRNA accounts for 1 to 5% of the human genome. It regulates at least 30% of protein. When the microRNAs are a little bit kind of thing, which are like a small lines there. The microRNAs is here, the yellow one. The yellow ones are a little bit like a comb shape of kind of things. So in the RNA, there's something called microRNA. The microRNA seems to be going wrong, off track for causing endometriosis. The microRNAs has been found to be the driver of the disease because it indicates that microRNA dysregulation is associated with endometriosis, because they found out in cancer, the microRNA seems to be the main thing to be studied. And endometriosis is just like cancer. They don't die of cancer. They die of cancer, but they don't die of endometriosis. So in cancer, the microRNAs can be a function of the oncogenes and tumor suppressors. So you find a little bit of comb kind of shape in the RNAs called microRNA. So the microRNAs are small, non-coding RNAs that collectively represents a normal class of regulators of gene expression. Specifically, microRNA, even to study that, there are several microRNAs, but I'm not going to confuse myself or yourself because it's not an easy job to understand as well. But they found out microRNA 9 and 34 may be connected to endometriosis. Because cell cycle progression, proliferation, and differentiation, the biological processes regulated by microRNAs via altered expression of target genes. The early secretory endometrium from women with endometriosis is characterized by microRNA expression profile that differs from healthy endometrium. So we know the answer is microRNA. So it's a normal physiological regulator of gene expression, and I'm sure the next 10 years, things are going to completely change. The drugs availability will be totally changed, and we will know the answer why there is progesterone resistance. The invasion occurs deep down in the variety of areas because there will be loosening of the cell-to-cell contact, degradation of extracellular matrix, acquisition of a migratory phenotype. There's an important study going on in this country as well. Epithelial to mesenchymal transition, all happening because of microRNA alteration or dysregulation. So we know that the technique has been kind of streamlined because they found it can be analyzed by the microRNA profiling, like cytometric methods, flow cytometric methods, and even real-time PCR. So you can imagine there are several microRNAs, and I don't want to name them because I'm not sure about that even now, because after reading all that, I just understand there's microRNA dysregulation. There are some which are low and some which are high. So there are huge studies have come up by Marine et al. MicroRNA 145 inhibits proliferation, invasion, and stem cell phenotype on these kind of different factors. MicroRNA 145 significantly downregulated in endometriosis. That means somebody having a low microRNA of 145, they will get endometriosis. Whereas microRNA 145 overexpression significantly inhibits endometriotic invasion. So I'm sure the pharma companies will come with drugs which will suppress microRNA 145, because 145 seems to be the overexpressed microRNA, and that will be overexpression is significantly inhibited. That means we want drugs to overexpress microRNA and not suppress that. So when we get overexpression, the endometriotic invasion goes down. How does it act? Because microRNA overexpression could result in downregulation of tumor suppressor genes. That's very interesting. Whereas microRNA underexpression could lead to oncogene upregulation, and inappropriate expression of microRNA is strongly associated with tumor-related processes in humans. Once again, to repeat, microRNA overexpression could result in downregulation of tumor suppressor genes. That is why The previous slide shows you clearly that how microRNA overexpression significantly inhibits endometriotic epithelial invasion. So microRNA proliferation, invasion, and stemness, etc., are the future generation to be thought of. And therapeutic potential. What's the therapeutic potential? Chemically modified microRNA antagonists. You're going to get antagonists, and that would lower the expression of all these kind of things. So what will be the future of these microRNA antagonists? I'm sure that's going to be very interesting. I'm sure next 5-10 years is going to change. The magic of microRNA will be understood. From regulating genes to aiding disease diagnosis, microRNA impact certainly is being evaluated. Hence, the small molecule makes a big impact. MicroRNAs are small RNA once again to express my thoughts by binding to and regulating DNA transcripts. Lots of gene regulation occurs. So this allows microRNA to silence gene expression, which is critical. Abnormal levels of microRNA have been associated with cancer. So I think we have to have some kind of a balance of endometriosis and cancer. So once again, the regulators of gene expression, they have emerged as attractive molecules to be considered as biomarkers, not yet established as a protocol. This regulation of microRNA suggests a possible mechanistic contribution and, of course, modulation of invasion as well as potential therapeutic targets. Cytokines are also a growth factor in endometriosis. I just mentioned about chronic inflammation. All the cytokines are also increased in endometriosis, and cytokines and growth factors have been dealt extensively before because cytokines are chronic inflammatory processes. They will increase angiogenesis, they'll have proliferation, they have inflammation, and so on. So endometriotic lesions are a whole lot of uh, kind of dysregulation of several things, increasing interleukins, interchronic inflammation, microRNA, angiogenesis, and of course progression. The couple of minutes on something called as endocrine therapy. All these while we've been thinking of the old targets like suppressing with progestogens, GnRH analogs, blocking the hormones. But the future thoughts will be these kind of microRNA antagonists, which will actually be intracrinology. Whatever happens is what is the concept of intracrinology means the peripheral tissue metabolism of steroids inside the cell. Endocrinology means outside. Intracrinology means inside the cell is now accepted as a key way in which endometrium utilize inactive steroids present in the blood to respond to local physiological demands, fine-tuning of activation and inhibition. What does it mean? If you look at this endocrinology, it's all because of hormones. The other tissues are affected. Talk about intracrinology. The future is going to be other than microRNA, something with the inside the cell. Because you look at this, estrogen comes from androgen, androgen comes from DHA, and so on. Now, if you can manipulate these, which I'm going to show you next, the red ones which have been earmarked there, the androgen gets converted to estrogen, that we know. If you stop that conversion of androgen to estrogen, that estrogen dominance would go away. So I think the novel targets would be, other than microRNA antagonists, there will be something to stop these aromatase inhibitors. Aromatase inhibitors, we know letrozole is available, but that's not the answer. There will be much higher aromatase inhibitors coming up in the market. The emergence of intracrinology is associated with disorders expression of key enzymes such as aromatase in endometriosis and as well as cancer. Development of drugs targeting these pathways opens up new opportunities for future therapies and precision medicine. To conclude, I would emphasize once again, understanding the pathophysiology seems to be not easy at all. I have done a lot of homework for all of you, and it's not the usual Samson theory and coelomic metaplasia theory. It starts with the confusion and future thought about the newborn bleed, inflammatory changes, stem cell changes, regulation of microRNA, and finally intracrinology. Thank you very much. Open for discussion after Hrishikesh Pai comments on that.
Thank you, Professor
Uh,
Pratap sir, for that informative explanation on the different challenges in the pathophysiology in endometriosis, as well as the new concept which you explained now. So we are still waiting for Professor Dr. Pai to join back.
but we can start the
So
question
now,
answers if you have the question.
yes, sir, we can move forward with the Q&A session. So before I begin the Q&A session, viewers, if you have any doubts or queries, please post them in the Ask a Question box provided below the video box and have them answered by Professor Pratap. Okay, sir. So the first question to you is from Dr. Kimia Padidar from Lucknow. She's asking, what is the best suppressive therapy after endometriosis surgery in a patient with history of VTE?
That means thromboembolism. Yes, it's a good question. I would suggest that we can give Dynogest or Genarch analog. You can give Genarch analog for once a month for 6 months or 3 months, but I think my experience of Dynogest is good because the thromboembolism is not highlighted by the Dynogest. Only when you give estrogen progesterone combination like OC pills, they would definitely get into venous thrombosis. So I hope I answered that question. Okay. There's another question whether endometriosis we could diagnose clinically and not necessary to laparoscopy. I think yes, I just spoke about the pathophysiology because we didn't talk about the diagnosis. But I always tell my people if there are 5 Ds: dysmenorrhea, dyspareunia, defecation pain, dyschezia, dull aching pain, and disorders of menstruation, I think that's what is the main problem there. And we know the diagnosis. And when we find by ultrasound, if you do a very good ultrasound, you can pick up even rectovaginal ultrasound. You can pick up basically in the pouch or Douglas out of the ovary. So the pathophysiology seems to be interesting because diagnosis, people have taken 7 long years to diagnose. So I always feel if a young girl comes with severe pain and you may not even find a cyst, there can still be the, endometriosis. There's another question by Dr. Alka Singh Patna. What's the difference between endometriosis and ovarian cancer in terms of signaling pathway? It's a very tough question, madam, to ask to answer that. But I now know endometriosis and cancer, they're a little sitting on the live wire. So when you find the microRNA seems to be the cause of cancer and it's the cause of endometriosis. So the ovarian cancer in terms of signaling pathway, I'm not aware of it because I'm not a gynec oncologist. But we now know that microRNA seems to be the link between endometriosis and cancer. Maybe the dysregulation of microRNA is very much compared to endometriosis. Dr. Pai, you would like to say anything?
I think I'm learning a lot from you. Everything is new to me and it's a good learning experience.
Yeah, that's what I just brought in some new concepts of basically on microRNA and intracrinology. I'm sure the targeted therapy would come in the next future, in the next decade. What's your
Fantastic
experience?
concept.
Yeah. Rishikesh, Bhai, what's your experience with ART and endometriosis? As a moderator, the future seminars I would be asking questions, but today I thought I'd ask you a question. Your experience of ART, pregnancies, and endometriosis.
So basically, I remember one of the first patients I had of severe endometriosis I had done from Manipal only many years back when I was in my initial phase in 1998. You had referred a patient to me and she had become pregnant. So my thought is that endometriosis patients, they definitely take more time to achieve pregnancy. Though there are no reports per se, but in my personal experience, the quality of oocytes and embryos is not as good as a patient without endometriosis. Though the literature doesn't say so, but in my personal opinion, secondly, I feel that the ovarian reserves are quite less in patients of endometriosis, and that's why mainly I feel that one second, I just go. There's some noise here. So mainly I feel that we should try to not do surgery on these patients. We should first try to remove their oocytes, freeze them, and especially patients who are not married. In these patients, we should freeze their oocytes prior to going in for ovarian cystectomy. That's the second observation. And and now the new guidelines that are there, the only indication for removing the endometrioma prior to ERT now is when there's severe symptoms of pain, or in patients where the endometrioma is large enough to come in the way of the oocyte retrieval. So, barring these two conditions, in all other patients, you can directly go for IVF, and you don't have to subject them to any surgical procedure.
I think excellent. We're going to have some other modules talking about the therapies. There's one more question by Dr. Anjali G from Pune. Can radiotherapy be used for treating endometriosis? The answer is no. What do you say, Rishikesh? We don't drink
No, you
radiotherapy.
can't. No, you
You
can't
can't
give
say
radiotherapy. It
while
will be
giving.
irreversible damage.
Yes. And Sanjana from Bangalore asking, what do you think could be the possible common cause of complicated ovarian cyst? That's completely different. When you say complications of ovarian cyst, I always say there are five things. MIRTH, MIRTH, malignancy, infection, rupture, torsion, hemorrhage. I always teach like that. MIRTH means happiness in English, but actually it's not happy to have a cyst. So MIRTH, malignancy, infection, rupture, torsion, hemorrhage. So we find that the possible common cause are because of the enlargement, the torsion, infection, and so on. But endometriotic cyst definitely gets infected sometimes, but hemorrhage cause severe pain. That's the difference. Kumudini Jha is asking, microRNA is not active before menarche. Why? Because microRNA is activated at menarche, and that is why it needs stimulation. That is why the microRNA we're talking about. Actually, it's a very interesting question because we don't know much about all this. I'm only reading recently about these new concepts. Because the microRNA probably seems to be, is again estrogen dependent. Whenever the estrogen increases, whenever they menstruate, that's the time they have ectopic menstruation, and then the microRNA seems to be coming in the pathophysiology. I think that's a good question. Anupama Gupta asking me, is there a medical treatment for endometrium or endometriosis? I think he's asking about, medical treatment. Where's the question? Is there a medical treatment for endometrium is written, but I think you meant endometriosis. Yes, I mentioned this now. Right now, the treatment seems to be the best with Dynogest because it's come from 19 testosterone derivative. And of course, you can also give OC pills, but OC pills has its own effect of thrombosis. Then there's the Dr. Leela. Dynogest along with ethinyl estradiol found effective in adenomyosis treatment. What's your opinion? We are going to have a separate session on adenomyosis, but I think any of these medical management, there is a lot of resistance in adenomyosis. It doesn't really work well. It just stops the menstruation, but it doesn't change the pathology. I found would think you can put intrauterine device Mirena even for an unmarried girl for some time. At least she has married people, definitely that's the treatment. Otherwise, adenomyosis is not very responsive, but you can give suppressive therapy for a short while. Sir, anything else, Rishikesh Pai? Or I think the questions are. Is there any other question from the audience? The organizers can tell us that. Yeah, there's one question. The ethnic link of endometriosis. Is there anything new? I'm unaware because Asians have a high incidence of endometriosis, maybe genetic composition of the Asians, but we find all over the world there's endometriosis. I don't think there's ethnic changes, but I'm finding we have a huge number of endometriosis in this country because, as you know, compared to the world, we are one of the leaders in endometriosis management and diagnosis. And of course, we have a huge number of endometriosis. Compared to UK and US, I think we are much more experienced than any other country. Nandini Chakravarti from Kolkata. How to deal with recurrent endometriosis following surgery? Rishikesh Pai would like to answer that.
If there is in recurrence, if suppose patient wants infertility, is on wants fertility in the future, then I don't think I would touch it unless there is again pain or it's a very large endometrioma which would come in the way of the retrieval. So the best way of preventing recurrence is by getting them pregnant in the first place. So It's a very difficult
Exactly.
call.
I think that's a good statement you made, Rishi, because people are operating every now and then. That's what's called recurrence. We should not operate when they're small cysts. You go ahead with IVF and then remove it. Definitely, surgery should be very less. And that is why recurrences are seen when you operate even a young girl who's not even married. So I think medical management has a lot of place. Anupama Gupta's question is there a medical treatment? I think we have answered that. Yeah, I've answered that. Medical treatment I've answered. Then I think that's all. We'll just wait few seconds. There may be some other questions coming up. Okay, we are well within time. Rishikesh Pai, you started this session and closing the session because you
Thank
are
you.
away from home, but still made it a point to come on the screen. I appreciate that. Dr. Amar,
Thank you, Pratap. Anything for
of
you.
course, Dr. Amar, thank you so much. Dr. Amar is
Okay.
asking a question. Do you know more about that? Why the VEGF was highly expressed in stromal cells but not in the epithelial cells of the change of the epithelium is the cause of this endometriosis. So that is why the VEGF is altered definitely. But your question is, do you know more about that? Why VEGF was highly expressed in stromal cells but not in epithelial cells? That is why in the national level there are a lot of research going on in this transition of epithelial cells, and maybe they'll get an answer for us. Aruna Muralidhar from Bangalore. Muralidhar, Aruna, the question is, what is your experience with combination therapy of Dynagest and LNG IUS for Endometriosis? I don't do combined things. I just do one of them. If there's a multiparous woman, I would put on IUCD with like a progesterone device. Otherwise, I would give Dynagest. Dr. Kanchan Sorte from Nagpur. How long Dynagest can be given? I have given for more than 2 years in an adolescent age group. In fact, one of my girls was a medical student. Somebody wanted to operate on her. I said no, 3 centimeter cyst, and she finished the course from Manipal. She went to America. She did residency there. She took it for 4 long years, and now she's fine. And the endometriosis has all gone away. So I told her now, since you finished all that US-based training, plan for a marriage, and that's what I think will be the answer finally. So you can give any number of years.
And if she can't get married, she should freeze her eggs.
Yeah, that's a good suggestion. She can freeze her eggs. I think that's a good suggestion. I can do that. I can tell my student to freeze the eggs at least. Correct.
There's a lovely paper by Anna Kobo. It's a long study where she has shown that in unmarried girls, prior to cystectomy, if they do freezing of the oocytes, is the outcomes are better than doing cystectomy and then freezing the oocyte.
Very good. There's one question by Dr. Renu Gangawar. Is danazol better than, what is better, danazol or Dynagest? As you know, danazol has been given up almost completely with very high androgenic problems. We only give Dynagest and not danazol anymore. And there is one question from mm, for Madhu Saxena. For hemorrhage ovarian cyst, what's the treatment of choice? Nothing. You just have to wait. If the total count is high, you give antibiotics. You just wait and watch. Hemorrhage slowly disappears and she'll be fine. The Renu Gangawar, I've asked to answer the question. Purashri Sharma from Guwahati. How long can we continue Dynagest? I've answered that question. I've given for 4 years and without any problem. But I think for 2 years for sure you can give. So I hope this pathophysiology makes you think a little more, though it is highly confusing. And I'm try to make myself a little simpler version of what I read. And I think the next 5 modules will be very practical and clinical. That's why I want to start off with the tough subject of pathophysiology. And I appreciate the president of Foxy elect, Hrishikesh, by chairing this. The first module is a very close friend of mine. So I wanted him to chair the session, and that's how it goes on the next 5 modules.
Thank you.
Yeah.
Bye.
I think there's one question. What's your viewpoint on the role of cabergoline in endometriosis? That's also good because that acts against vascular endothelial growth factor. I do give Dynogest, but sometimes people still have some pain. Then I think I give cabergoline zero point 0.5 milligram twice a week for any treatment 6 months because they will ovulate. It doesn't suppress ovulation, so the pain goes away, and they may even they conceive also. So I think cabergoline is a very good choice because it is not the first choice. Dynogest is first choice, but somebody trying to become pregnant, I think cabergoline can be done. Nidhika Chabra, my old student. So, what is your viewpoint on the role of cabergoline in endometriosis? I think I answered that just now. There's another question as well. And Aruna Muralidhar, one more question from you. Surgical management for infertility due to endometriosis no longer done? No, it's done. We cannot say no longer done. It is done, as Dr. Hrishikesh Pai mentioned. If there's severe symptoms and, of course, she cannot tolerate that pain, I think surgery still has a choice. But avoid surgery when there are just minimum symptoms and a small cyst. You can directly go for IVF and then remove the cyst. If ovulation induction was the first choice is clomiphene citrate for ovulation induction. Sridevi Velanki from Vijayawada, again my old student. So, what is Dynogest effective in scar endometriosis? I think I have tried in scar endometriosis in few cases. The response was pretty good, but it's not 100%. So we can try Dynogest for scar endometriosis, but the treatment is ultimately surgical. I've had couple of my patients complete resolution of endometriosis, but if it's deep down, see, as we know, endometriosis is not, initially we thought is on track from the wound to the cesarean scar. It's not there. The technique, what we have done is wrong. Cesarean section, we went and mopped the uterus for no reason or rhyme. And all that kind of, the endometrium, which you have only transposed into the scar. So I feel it's a tough cesarean. You must wash the subcutaneous tissue. You should put saline, wash it, remove the endometrial cells. That is why the technique of cesarean is the choice. If it's not done well, they will get endometriosis. But your answer is Dynogest. You can try that. Within 3 months, if they don't respond, you can do surgery. Dr. Neela Mishra asking if endometrium not respond Dynogest, can we give Depot? No, ma'am, Depot doesn't really work well. The medroxyprogesterone acetate that doesn't work well. Because if it doesn't work well, you can try letrozole. I just told in my pathophysiology how aromatase inhibitors is one of the problem there. You can give letrozole 2.5 milligram daily continuously, and they sometimes respond well. And you can even give cabergoline also in those kind of patients. There's one more question, Dr. Piali from Howrah. Would you I cannot read that, cite that. Would you say that the treatment of endometriosis and adenomyosis differ? Dynogest is claimed to work in both cases. There's a difference because adenomyosis is not so responsive and endometriosis is responsive. But if you heard my pathophysiology talk, you would understand that there's a resistance of progesterone by itself. So we now know that both are different, and adenomyosis doesn't really respond very well. It's only the endometriosis responds well. Dr. Isha Goel, Dynogest alone or with estrogen combination, any difference? I don't give estrogen combination for endometriosis because estrogen may flare up the endometriosis. So I would select Dynogest alone because it has been reported that OC pills may flare up deep infiltrating endometriosis in the future. So I think Dynogest is the single one is better than the combination, but I know combinations are also being sold. I don't have experience in that. Savitri Ramesh, my old colleague from Manipal, being in Madurai now, is asking how long we can wait for the hemorrhagic cyst to disappear. As per rule, it disappears in 3 months. Usually by 1 month it goes down, but it may take about 3 months. By 3 months it goes away completely. So good. A lot of questions are coming up. One more, Nidhika Chabra's question: will letrozole given for long in such cases will cause hyperstimulation? Yeah, it's a good question, but I think when you give on the long term, it suppresses all these kind of Those anti-estrogen itself, isn't it? Suppresses estrogen. So when you give for a short one, it's like a stimulatory protocols for IVF and IUI, but in endometriosis doesn't cause hyperstimulation syndrome. That's a very intelligent question. Nice question. Yes. So we can conclude because we are almost on time for this session. And on my own behalf, I must thank Dr. Hrishikesh Pai for having come on this session. And
Thank you, Dr. Pratap, for inviting me for the session. It was a pleasure and I learnt a lot from you. Thank you.
thank you. So the doc mode, would you like to wind up or Akumentis? Yes, you can. We'll flash the modules for the next 5 modules. I think I would read that out. I just want the audience to see it's going to happen every Thursday. On the first Thursday, not every Thursday, first Thursday. This is the first module by myself, chaired by Hrishikesh Pai. The second would be on June 2nd, deep infiltrating endometriosis, difficulty in diagnosis and management. He's a very good surgeon from Spain, Alberto Vasquez Rodriguez, and will be chaired by Dr. Nandita Palsherkar, and that's on 2nd of June. The module 3 is going to be 7th of July, understanding the pain in endometriosis and management by a consultant from UK, Dr. Sia Sharan Sharma, our own Manipal student, the consultant in reproductive medicine in UK, chaired by Narendra Malhotra from Agra. And the 4th module will be on August 4th by Dr. Madhuri Patil of Bangalore. She'll be talking about ovarian stimulation and its difficulty in endometriosis, chaired by Dr. Jaideep Malhotra from Agra. Module 5 will be choosing the right medical management in endometriosis on September 1st. Speaker will be Dr. Sonia Malik from New Delhi. Chairperson will be Dr. Rishma Pai from Mumbai. Module 6 and the final one will be endometriosis and tackling by surgery. Tips and tricks from a very good surgeon from Malaysia, my very good friend, Selva. I call him Selva. His name is Sevella Raja. He'll be chaired by Dr. Jayakrishnan from Trivandrum, and that will be the last, will be October 6th. So, my dear friends, please look into these. I've taken a lot of pain to select the speakers and the chairperson, and a lot of efforts have gone into choosing the topics for the next 6 months. I appreciate Akumentis, Harmonica, and Doc Mode for having supported me completely for this 6 months academic, extravaganza. So, Subhajit.
Yeah, thank you, Dr. Pratap, and thank you, Dr. Rishikesh. It was a wonderful program. And in fact, it's very rare to have so many questions. I counted it is somewhere around 45, 50 questions. So it was really great, absolutely. And whichever questions will remain, we'll ensure that we'll send it to you via email in a few days' time, basically. That's part one. Part two is I'll request doctors that are Harmonica field people, our business managers and their leaders will be coming to you for registration. Those of you who have not done the registration, will request you to get it done as soon as possible so that you are in a better position to view this. Though this one we had put it on YouTube, but the next one would be on a registration basis because this is as per the university norms where there is MCC, I mean, there is credit points at the end of the program. So the registration is a must. So we will ensure that we come to you the balance 20-25 days remaining before the second module and get you registered. In case anybody does not come, you can always write back to us. In fact, at my number or anybody of Harmonica Akumentis, and we'll come to you immediately. Thank you very much. And thank you, Doc Mode, for being our partner this. Thank you very much.